Okay, gonna warn you, this is going to be a long one. Okay, because we're going to be discussing hepatitis. Okay, hepatitis. Anything in an itis means infection slash inflammation of. Infection, inflammation of hepatic tissues, the liver. Hepatitis is a disease hallmarked by inflammation, swelling of the liver that can over time lead to either cirrhosis or necrosis of hepatic tissues. The inflammation is going to cause swelling of the tissues and rearranging of the architecture. Okay? Rearrangement of the architecture could lead to piss poor blood flow in and out of the liver, which means some cells are going to get starved. Starved cells die, hence necrosis. Low level necrosis, low level cellular dying could lead to just scarring, what we call cirrhosis, or it could be to a lot higher level of cells dying off and going beyond the scarring to you begin to see abscess formation. One of the hallmarks of hepatitis is going to be jaundice. That's the yellowing of the skin. The sclera, which should be whitish, of the eyes is going to start to take on a dark yellowish tan appearance. This is because bilirubin is accumulating in the blood and then leaking out into the surrounding tissues. Bilirubin is generally removed by the liver from the blood, so it's not generally not a problem. There are quite a few viruses that can lead to jaundice, can lead to hepatitis, like inflammation of the liver, cytomegalovirus, Epstein-Barr virus. But the ones we're going to focus on here for this mini lecture are the hepatitis viruses A through E. Okay, there are, was that A, B, C, D, E? Hold on a second, I got to count on my fingers. A, B, C, D, E. 5 different hepatitis viruses that infect us humans. There are many more out there, but they are not human, or they don't infect us. So we don't worry about them in a course like this. Hepatitis, A and E viruses. Okay, we're going to do A and E, first and fifth first. Single-stranded, non-enveloped RNA viruses. Okay, these are going to be fecal oral. You ingest fecally contaminated water, food, virus starts to infect. Virus spreads. Virus preferentially targets hepatic cells. One goes in, hundreds, thousands come out. Some of the viruses will spread to other hepatic cells, other liver cells. Many of the viruses will then go out the bile ducts, gallbladder, small intestine, large intestine, out with the feces. Generally, for most people, hepatitis A and E is going to be subclinical, or the symptoms are going to be so low level. Oh, I think I had the flu, or something like that. Gonna be, oh, I just haven't been eating right for a while. So my, doctor's saying my liver is showing a little swollen, a little bit of fatty liver, things like that. Severe cases will start off with those vague flu-like symptoms, and then a few weeks later, maybe a month or so later, the patient will present with the onset of jaundice, and their liver will truly be swollen from the inflammatory response. Okay, it is palpable how swollen their liver will be. And then it will just progress from there. Generally, hepatitis A and E are not thought of as oncogenic. They don't insert into the host cell chromosome and lead to mutations. For most people, after a while, they will recover. The immune system kicks in over time, is able to clear out the viruses. A few weeks later, the inflammatory response has settled back down, and they're okay. The A&E transmission is generally associated with either poor hygiene or lack of any type of public infrastructure. Sewage is able to get mixed into the water supply. Personal hygiene for either the person or somebody preparing the food. You go to countries that are less industrialized, where the infrastructure, public infrastructure, is not quite there, if completely absent, and hepatitis A and E is going to be all but endemic. Um, since there is a component of viremia after ingestion of the virus, they have been able to show that hepatitis A can be spread via blood or blood products, sharing of the needles, things like that. Most cases here in North America and Europe are going to be adults. Okay, adults ingesting fecally contaminated water, food, and or sharing of needles. We now have a vaccine, Hep A vaccine. It's an activated virus, means they go through and they chemically or heat inactivate it, break it down. So here's the components of the virus. Your immune system learns the virus. Good to go. Harvix is generally administered post-exposure. You think you may have been exposed. You'll see this law enforcement, healthcare workers, law enforcement patting people down, go to see what's in their pockets, may get jabbed by um, a used syringe, or they're reaching into bags or pockets or clearing stuff out, get jabbed that way. This is one of the things they worry about, along with HIV. A little lesser on the HIV, more on the hepatitis. Um, Nurses, for those of you listening to this and plan on going to nursing school, yeah, and you're going and you're injecting stuff into an IV line or IV bag or into a patient, it's gonna slip, go all the way through, and you're gonna jab your own finger. It happens to a lot. So that's one of the things they worry about. Harvix is post-exposure, generally what you're gonna see. It's also one of the things they have to worry about for AIDS patients. Okay, they get exposed, and AIDS patients get exposed, their immune system's not going to be there to clear it out. Because remember, it's T cells, CD4 cells activating CD8 cells. CD8 are the killer cells that go and kill virus infected cells. CD4 gone, which means minimal, if any, CD8 cells will be activated. So AIDS patients can't clear this out. They will never recover. Now, Hep B and Hep D. Let's talk about these two. Hepatitis B virus. Well, now we're looking at an enveloped DNA virus. Remember, A and E were naked RNA viruses. Hep B, enveloped DNA virus. Okay, why do we still call it hepatitis if it's a different genome? Because it still infects the liver preferentially. Okay. The enveloped DNA viruses, you'll see, was it double-stranded or partly single-stranded genome. So it's a little wonky. It's something we haven't seen before. Remember, during our virus chapter, we talked RNA, DNA, double-stranded, single-stranded. Well, this one's DNA with a little bit of single and double-stranded action going on here. It's an envelope virus. One virus goes into a liver cell, hundreds, thousands come out, pulling along with it parts of the cell's cytoplasmic membrane as its envelope. Well, enough of those leave the liver cell's just going to burst, and it's going to release hepatitis B capsids. Capsids alone are known as Dehn particles. And there is some question on whether or not these are infectious on their own. Hepatitis D are a special type of RNA virus. D is only infectious. D can only get in and do its thing into a cell that's already infected by hepatitis B virus. They call this a co-propagation. A cell that gets infected with D, nothing happens. Cell that's already infected with B gets it infected with D, well, now D can propagate. One goes in, hundreds, thousands come out. Apparently, D must harness some of the same cellular machinery that B has already co-opted. So if you think about it, one goes in, hundreds, thousands come out. You have a direct cell damage, cell death. Neighboring cells in a few hours, few days will also start to die. So you have direct damage to hepatic cells that way. But we also see with hepatitis B, patients that present with that are also going to have other issues. They will talk about malaise, anorexia, diarrhea, nausea. Hepatitis B can progress as this abdominal comfort, diarrhea, nausea starts progressing. We also see that there is some kidney interaction. That the infection with hepatitis B, through some different mechanisms we're not going to talk about here, can lead to the development of what is referred to as glomerulonephritis. Okay, glomerulonephritis is basically inflammation within the kidneys. Okay, means there's going to be some issues within the kidney that's going to be affecting arterial flow. No arterial flow or impeded arterial flow means that the kidneys will not be able to get out all the excess salts. Blood chemistry is going to go completely wonky. HBV, hepatitis B, generally this is the one we more closely relate to severe cirrhosis of the liver. Okay, this chronic liver inflammation will lead to some form of cirrhosis, minor necrosis. If the immune system does clear out the infection before necrosis hits, there still may be some cirrhosis, but the inflammatory response will go down, and it turns out the liver is constantly regenerating itself. Damaged tissues will regenerate. Cirrhotic tissues have lost that ability. So the scarred tissue will always be there. The remaining tissues will regenerate, and complete liver function will be restored. For a very small percentage of cases, HBV with that chronic inflammation, the cirrhosis and the scarring, will lead to some form of liver cancer. when you get infected will impact the severity of the liver damage. Cirrhotic versus necrotic versus cancer. Early childhood, infancy, neonates get infected. Fecal contamination, vertical transmission, whatever, will develop a chronic infection which will lead to liver damage. After the age of 5, the percentage of chronic infections, that long-term infection, and the cirrhosis and necrosis, possible cancer, those levels drop. So you could be, so those of you listening to this at your age group, early 20s, you get infected, the chances of it going, chronic and the cirrhosis, necrosis / cancer is actually quite small. You get infected in time, you can clear it out for most of you. If it does develop as a chronic infection, well, then it has a mortality rate of 15 to 25% due to that cirrhosis, leading to impaired liver function, necrosis leading to organ death, and the cancer leading directly to death of the patient. Hep B is generally going to be not a fecal oral. I know I just said that earlier. I wasn't thinking. Hep B is going to get in through the membranes, mucous membranes, break in the skin, mostly by injection. It's going to get in the skin, it's going to get in the blood, viremia, and it's going to preferentially infect hepatic cells, the liver. Incubation, 1 to 6 months, 4 to 24 weeks. Okay, so you may have gotten exposed and you won't know it for another month, 1 to 6 months. Generally, those people who do get exposed, do get infected, are going to show minimal, if any, symptoms and will develop an immunity. Since the liver is highly vascularized, one virus goes into a liver cell, hundreds, thousands come out. Well, not only are those viruses going to diffuse and directly hit neighboring liver cells, but they're also going to come into contact with a lot of blood vessels. So they are constantly being introduced into the bloodstream and carried throughout the body. Transmission, as I said in the previous slide, injection seems to be it, but also absorption through mucous membranes. So HBV is one of those that can be passed via sexual intercourse, delivered via semen or vaginal secretions. Needle sticks is going to be a problem for those of you who are going to be clinicians, PA, nurse practitioner, nurse, whatever. You have to be very wary of where the needle is, where it's been, where it's going. As I stated in a previous slide in this mini lecture, HBV is going to be a big concern. Diagnosis, serology, test for the presence of antibodies to HBV. That will tell you was there an exposure over 2 weeks ago, because remember it's going to take 2 to 3 weeks for your immune system to learn something new. Or you can test directly for viremia. Is the virus present in the blood? So you can do a serological test, and ELISA will tell you yay, nay, presence of antibodies, presence of antigen. Prevention for HBV is vaccination. Okay, use the vaccine. Most medical dental workers and some for people who are going to be interacting directly with patients. Patients who are going to be immunodeficient or for cancer treatments, things like that, and there's a chance they could be exposed, will get the vaccine. So while their CD4, CD8 numbers may drop, hopefully their B cells remain, so they're at least making antibodies to opsonize and keep the virus from being able to adhere to its receptors. Question students ask, well, why not hepatitis D vaccine? Well, if you're vaccinated against HBV, you can't get infected. So if you ever get exposed to D, D can't get in, D can't do anything, remember? Because D has to have B already there. If you have been exposed and you test positive, the patient, for the patient, what you will do is passive immunization. Basically, that means you're going to inject into the patient antibodies, hepatitis B immunoglobulins from another patient who was either vaccinated or had the disease. The antibodies will bind to the virus, they call that opsonize, and it will act as a barrier so that the virus can't touch its receptor, thus there's no uptake. Innate immune cells, macrophages, neutrophils, will then be able to quote-unquote recognize the virus as being there, and then we'll phagocytize it. And then finally, hepatitis C. Hepatitis C is causing a major issue, okay? Right now, 3.5 million Americans are infected with this. This is about almost 1% of the US population. Its incubation period, or its time before you start to, the patient will start to present symptoms, could be years. Hepatitis C, its infection of the liver will lead to liver transplants. Here in the US, it is the leading cause for the need for liver transplants. Symptoms-wise, symptoms are going to overlap many of the other hepatitis I've discussed during this lecture. Even with the liver transplant, there is still a potential for that patient to still be carrying somewhere in their body hepatitis C, so that new liver could become infected again, or become infected, thus leading to liver failure once again years down the road. Hepatitis C, it's not going to be fecal oral. This one is either blood transfusion or injected, dirty needles, okay? Needle stick. There have been cases of vertical transmission, okay? Mom's infected, it's in the blood, viremia is able to cross the placenta into the fetus. Or during birth, passage out. It's a bit bloody. Neonate's been exposed. No vaccine for hepatitis C. Okay, this one still treat, supportive care, try to keep the liver going, happy, 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 if need be, when it hits a certain point. Um, Liver um, donation, gonna have to go in for and get a new liver. They are looking at some drugs. Um, Sofosbuvir is a nucleotide analog. Um, an analog, remember, it kind of looks like a nucleotide, but it's missing some key components. So it will get inserted into the viral genome, and it will then interfere with genome replication and genome or viral gene expression.